โอเคขึ้นแล้วน่าจะขึ้นละตอนนี้น่าได้ละโอเค
Hokkaido.
Okay.
Just for 2 weeks ago. Yeah, for her summer break. From time to time, usually when according to her schedule.
Her school's good.
น่าจะขึ้นแล้วล่ะ
School break, we go travel somewhere.
Good.
อ่า
Does she
ขึ้น
come
ทุก
to
อันเลยแหละ
conferences with you?
Yeah.
She does, right? Good. That's important.
Not in the US yet. It's a quite a
Asia
long
mainly.
flight. Maybe soon. Yeah, she go enough, and she want to like go to national parks. She watch YouTube.
Mm-hmm.
To see
See the world, right?
Calgary.
เนี่ยขึ้นแล้ว
Canada's
นี่ไง
beautiful.
หน้าตา
Canada's
ไป
beautiful.
ขึ้นหน้าตา
You know, have you been? Have you come to Canada?
Once.
Vancouver?
Long time ago, yes.
Yeah, Vancouver's nice. Dawn was just there with me. We were doing some work together on some courses. I did a surgical wet lab at our national meeting. I gave many lectures. Dawn helped support those. We did some jet
ขึ้นละ
skiing.
มันขึ้นแล้วล่ะ
My
โอเคละ
daughter was there. She went jet skiing.
มัน
with
จะดีเลย์
Dawn.
ประมาณ
It was good.
10 วินาที
So nice, you know, family and fun is so important, right? Otherwise, I don't like leaving my kid at home.
Okay. Okay.
Ready?
Okay.
No?
Sure. For sure.
I'm yours.
Good evening. Today we have the great honor and really so pleasure to have my best friends, Professor Karim Punja from Calgary, Canada. He come to Thailand several times since 2006, and we invite him to provide the lecture today. So the lecture today, we have the set up about to lecture with my colleague, Dr. Kanchana, will come to be co-moderator together. So we a little bit late for the session, so let me start his lecture today. First of all, Dr. Karim Punja was my co-fellow in 2003 and 4. We studied together at Chile Eye Center in the Oculoplastic surgery with my mentor, Don Kikawa. And after graduated, he came back to Calgary and opened up his private practice and his academic practice. And he got so successful, trained the people, more than 20 fellow in Canada. And after this, my colleague, Dr. Kanchana, will introduce Dr. Punja. Yep.
เฮียก็พูดไปหมดแล้ว
Okay, Dr. Kanchana,
Hello,
thank
good
you very much
evening.
to
Okay,
be here.
thank you.
Thank
My
so much.
honor, my honor. ค่ะ It's probably not very official, maybe more casual. Okay, Dr. Karim Punja, one of the oculoplastic surgeon that I know for quite some time. 20 years.
20 years.
I don't want to say that long.
Don't want to say that. I know.
Dr. Karim, he graduated from the University of Calgary. No, you are working
yes.
right at the University of Calgary as a clinical associate professor, and he is head of ophthalmology fellowship program and director of oculoplastic surgery. He trained a lot of fellows in domestic and international.
Right.
Okay, and this is his
Eye center.
His building. I mean, like.
It's an institute.
Yeah, the institute is quite big. I never ever been there yet, but Dr. Nathawood been there, and yeah, he showed me how it's like quite a big facility, buildings, and a lot of staffs. It's Orbit Eye Center, and he is a medical director there. It's our honor today to have you and lecture to us about your work and your experience. Today we focus 2 lectures. One is about the mid-phase rejuvenation, and the other one is a frontalis flap, right?
Correct.
Okay. So we start for the first one, okay?
Thank you. Thank
Please,
you both.
Dr. Karim.
Thank you both for this very, very kind introduction. It is a sincere pleasure and honor to be here amongst our esteemed colleagues, amongst academics that aspire to advance science, advance medicine for the benefit of all of our patients everywhere, patients in Canada, patients in Asia, patients in Thailand, and it's that passion for academia and patient care that binds us, keeps us all together as an alumni, as colleagues, and as esteemed faculty the world over. When I first told Professor Natawut that I was coming, he said, well, perfect, you must speak. And I said, no, I'm here with my daughter. She is going to United World Colleges for a summer program. But he goes, no, you must. He insisted, you must speak. You must share some knowledge. It is our duty, it is our obligation, it is our responsibility and my privilege to be here. So thank you both Dr. Goff, Dr. Panita, as well as Dr. Nu Kanjana for this opportunity. I'm not sure who all is able to tune in, but thank you for giving us the pleasure of your time. Dr. Goff, is there opportunity for interaction as we speak, or should I give the lecture and then the discussion after? What's the best format?
We let you follow the lecture for 20 minutes, and we have the question for 10 minutes.
Perfect, thank you. So let's proceed. So I have no financial disclosures. I also wish to thank my co-author, my current fellow, Dr. Antonio Florido from Italy. So whenever I give this talk, I always tell my students, my audience, it's so critical to embark on these things with principle, with understanding, and with good resources. Although so many things truly are available online, I still appreciate and enjoy books, paper books, and it's these books that have guided me, have guided my fellows. These two by Zaid are no longer available in print, but there's some kicking around on eBay and elsewhere that are critical anatomic foundational books that augment some of the online beautiful video anatomic dissections that we have. And of course, I'm a big advocate of Dr. Korn and Kikawa's book. There's a second or a third edition. It's phenomenal, and many of the diagrams that we refer to today will be found and can be referenced there. So let's begin. As aging occurs, this is the nice youthful midface on your left, and on the right an aged midface. So as aging occurs, there's descent, demarcation, and deflation. And a cheek descends. That results in deepening of that nasolabial fold, the nasojugal, and the malar folds. And now we see the inferior orbital rim is visible and unmasked and does not look youthful. And this leads to the classic double convexity deformity that was described by Hamra that we see on the right, as compared to the smooth single convexity of youth from my young fellow, Dr. Florido, on the left. So our goal is to restore that single youthful, single convexity as much as possible. So let's go to anatomy, the principles. You can see the orbital septum, the orbital malar ligament, first described by Kikawa, the superficial musculoponeurotic system, and the suborbicularis oculi fat. And of course, the midfacial retaining ligaments. So that's a youthful sagittal diagram of the midface. So what happens with age? There's laxity of these structures. Lucarelli first described attenuation of the orbital malar ligament, which results in deepening of the malar and the nasojugal folds, inferior migration of the orbital fat, as well as of the SU for the suborbicularis oculi fat. That combined makes us look not as youthful as we used to. So let's again look at anatomy. When we're looking at the lower lids, we've got our three classic fat pockets, the nasal, the central, and the temporal. They're divided medially by the inferior oblique muscle and laterally by the arcuate expansion of the inferior orbital muscle, inferior oblique muscle. And let's look at the cadaver dissections of the face. So on the far left, we can see if we just cut the skin, pull it away, we see the first layer of fat. That's the subcutaneous fat. When we go to the next layer, we see the next layer of fat, but that's actually the superficial musculoponeurotic system that's in the middle. After we go through the SMAS, we then get to the suborbicularis oculi fat. So really the midface is this composite of different fat compartments. Knowing those fat compartments, understanding where they belong, how they become attenuated, how they change with age is important in knowing how we can restore more youthful anatomy. And of course, knowing the critical structures, knowing that along the SMAS in the middle, just underneath it is the cranial nerve 7 and all of its branches, understanding where they are, avoiding them, and knowing these danger zones and the safe zones are essential elements of a midfacial surgeon. So the orbital malar ligament is this tough ligamentous structure emanating from the inferior orbital rim. It extends through the orbicularis oculi muscle to insert into the dermis. And the malar and the nasojugal skin folds correspond to the cutaneous insertions of the ligament. It was Kikawa and Lemke and Dortzbach that first described this, and it was published in 1996. Thereafter, Dr. Lucarelli looked at cadaver dissections and saw that there's elongation of the orbital malar ligament. Here we see that tough, robust band of the ligamentous structure. It's stout and robust and strong laterally there, which we can see on these diagrams. And Lucarelli in his landmark paper described elongation and what happens with aging. And so if we understand what's happening with age, we try to restore that youthful anatomy. So what are the goals? Well, we want to elevate the midface, establish that support. We want to reinforce the orbital malar suspension. We want to address the soft tissue deficiency over the rim by redraping the unmasking of that skeletonization of the midface. We want conservative skin excision if needed, horizontal tightening, and then functional surgery to support the lower eyelid if there's retraction or ectropion. So let's look at a case, a vignette here that really describes this. With my finger, if I just tighten that horizontal eyelid, you can see that what's actually happening there is, Pishai, I can't see the... I'm going to go back for a second here. Thank you. So you can see when I pull my finger up, the eyelid translates the forces to the cheek. So if I just tighten the eyelid itself, it's inadequate in restoring the anatomic dysfunction. However, if I use my thumb there to pull the mid-cheek, the mid-face up, and then hold my finger laterally, that combination of lifting the mid-face and tightening the lower lid will help restore the anatomic dysfunction. So let's look at that on a video. So this video will highlight the relevant anatomy and the salient steps of pre-periosteal mid-face lifting along with lower eyelid blepharoplasty. So this is the CO2 laser doing a standard swinging eyelid transconch lower lid approach. Release the canthal tendon, swinging eyelid, go transconch, releasing along a preseptal plane. I'll put in a traction suture. Next, with the coag, I can release the orbital malar ligaments, the midfacial ligaments, the zygomatic cutaneous ligaments, and I'm going medially here as far as the infraorbital nerve branch, and laterally I extend to release the entire ligamentous structures along the mid-face. That's the orbital malar as well as the zygomatic cutaneous ligaments, because we're along the zygoma here. This whole bony structure where I'm dissecting is along the zygoma pre-periosteal. This is a relatively safe plane as long as you're deep and avoiding the neurovascular bundles. Once I have that wide exposure, I can also address the lower lid fat, which we're going to show in a subsequent video. You can see I'm pointing to the rim. I've dissected fairly far and fairly. Now with the freer, I verify wide release down to the malar eminence. Now I'm going to debulk some of that lower lid fat. This required a subtractive technique. And you can see I do this under local anesthetic. The patient is awake, they're comfortable, they're not in pain. They're completely anesthetized.
Local or with
Local with some sedation, yes, correct. So this gives me access to the midface as well as the lower lid. Now with the forceps, I'm pulling the SMAS, and you can see the translates force all the way down to the mandible. That verifies that I've got the right structure to elevate the midfacial structures. This is a robust 3/0 vicral suture. Once I pass it, again, I put some traction on it to verify that I've engaged the correct tissues. And then I secure it to the periosteum of the zygoma laterally. It's very easy to overcorrect and over tighten, so I don't bunch it up too much. I actually ask the patient to open and close their mouth to gauge the amount of tension, so I can titrate that. You can see that's happening there. And then I will add another suture if needed. So there's a second suture being placed here immediately. Again, I verify my placement. Another 3/0 vicral. Again to the zygoma. This is closer to the lateral orbital rim. And it's very easy to overcorrect the suture. It's also very easy to make this suture go too superficial, and then it can cause dimpling of the skin. Then I denude some of the lateral tarsus so I can address the horizontal laxity. And doing a mini tarsorrhaphy here at the same time, and this patient required it. Again, a 3/0 vicral. After I've shortened a little bit of that tarsus, re-anastomostat to the periosteum of the zygoma, lateral orbital rim, canthal reforming suture, and then we close the skin. Let's look at some other key steps here. Let's look at the blepharoplastic component. So again, canthotomy, cantholysis, swinging eyelid. And the sagittal diagram here shows you exactly where we are. And we're trying to address the attenuated ligaments, the overriding fat that's prolapsed. So I'll put that on traction. This is the blepharoplastic component shown more clearly. So you can see the fibers of the septum being released. That's along the central lower lid fat pad. I slowed that down a little bit so you can appreciate the different fat compartments, some debulking of that fat compartment, and you can see with the corresponding sagittal diagram where we are along that midfacial structure. Address any bleeders. And then similar to the other video, we release the ligaments. So, people talk about various compartments in which you can dissect when you do a midfacial lifting technique. Should you go subperiosteal? Should you go supra or preperiosteal? This animation shows that when I go deep, because there's so many glide planes in the midface, even though I've engaged the subperiosteal plane, it doesn't translate as effectively superficially. But if I go preperiosteal and I grab that tissue, it's more effective in lifting up the superficial tissues. And that's a pearl that took me a little while to learn early into my practice. If I went too deep, I wasn't getting adequate lift. When I went more superficial, I got more effective lift. So if we look at this patient before and after, so he's 18 months post-op, and you can see that the eyelids are in good position. It's been effective, it's durable when the technique is used effectively. There's vertical shortening of the distance from the lid margin to the skin crease. And that's what we see in a more youthful eyelid. And so we've effectively restored that anatomy. You can see the attenuated septum, the orbitomalar ligament, which has now been tightened and restored into more of its anatomic state. Now this is a functional patient. It's not a cosmetic patient. But this technique works very effectively in functional as well as aesthetic patients. So if we look at side profile, we see more of that restoration. The eyelid is ectropic, it's retracted, and it's restored to its more anatomical state. So let's look at a more youthful patient that came to me looking for an aesthetic rejuvenation. When we look at his lower lids more closely, we can see the fat prolapse, the attenuation. It's smoothened out. That double convexity is restored to more of a single smoothened convexity. That shortening of the crease distance from the margin to the crease junction that we see in a youthful eyelid has been restored in this gentleman. So I hope you can appreciate that if we address the mid-face while we do our lower blepharoplasty, it's a more effective and it's a more principled manner of correction for rejuvenation of our patients. It's very easy to overlook this cheek tissue. Also remember, when you're doing blepharoplasty, the eyelid is the area from the lid margin all the way to the upper mandible. So when you're doing blepharoplasty, you're working on the mid-face anyways. If you're working on the mid-face and the lower lid, add that extra couple of steps, elevate the cheek fat pockets, resuspend, re-achieve a single convexity. It's a more durable approach. Your patients will appreciate it for years to come. And this speaks volumes about your quality as an oculofacial plastic surgeon. Because after all, we're not just eyelid surgeons, we're facial plastic surgeons. And understanding the critical anatomic structures in these areas will allow us to get the results that both we desire as well as what our patients desire. I tried to make up for some lost time. I want to thank again my co-author, Dr. Florido. This is where I'm from, Canada. It's not this cold right now, but certainly about 9 months of the year, we've got some really good opportunity to be out in the mountains, get some fresh air, get some skiing in, and reconnect with nature. You've got the beaches, we've got the mountains, and the snow. Thank you for listening. Thank you for your time. Let's welcome some questions from the audience.
Some questions. In terms of augment the mid-face, not only the lifting, but volumize. What do you think about the injection of some fat or any redraping of the fat for augment the mid-face?
That's a great question. In fact, more and more we're realizing that instead of just discarding that precious fat, I believe the next steps are actually to take any of the fat that is subtracted, mince it, and then simply replace it and re-inject it along the mid-facial fat compartments in order to try and act as your own autologous filler. We are all losing volume, especially after the third decade of our life. Trying to realize our own natural filler as much as possible, or I've got plenty, and we can take some of this.
Me too.
And do some liposuction, process the fat, and then deposit it into the mid-face as part of one of our tool kits is definitely not just a trend, but I think it will be a part of the paradigm shift in terms of how we remedy and deal with the rejuvenation for our patients, both men and women. Yes, correct.
So mostly you do the lower blepharoplasty from the transconch mainly?
Both. No, this was a nice video. I also do transcutaneous. We all have our own go-to approaches. I always find when I go transconch, I have a better access to dealing with my fat compartments, redraping when I need to. I know my metrics for when my endpoints are. And then in terms of the extra skin, it's really seldom that I take more than 3, maybe 4 millimeters. That can easily be achieved with a subciliary incision, little pinch, subtract that, and then I tack that on and reposition it and redrape that skin.
Do you have any tips compare like a Caucasian and Asian eyelid?
Yes, the fat compartments are very different. The orbicularis tone is
Right.
very different. They are very, very different structures, and having the opportunity to work on patients that are aged in both of those ethnicities and then translating it to people as young as you it takes experience to know where normal is, and then knowing where and how much to subtract or redrape in order to rejuvenate that individual. And the other thing that I tell my fellows is an Asian is not an Asian is not an Asian. A Thai Asian is different than a Chinese Asian, is different than a Taiwanese Asian, is different than a Japanese Asian, is different than a Filipino Asian. And they're very blurred because there's so much pluralistic exchange. And so understanding some of those points, what really helps when I'm looking at an Asian patient is I always ask for a photo of what they looked like 10 years ago, 20 years ago, so I can understand what their facial harmony looked like. With an Asian patient, I also think it's important for me to understand what their reference of beauty is. So I ask them to bring in photos of contemporary models or mainstream media individuals that they can reference for me, so I understand what is their end game, what is their goal. So we're aiming for the same goalpost. But however, it's also important for me to know and to coach our patients to say, is that achievable? Will that look good on you? Because we're beauty experts, we're beauty professionals. They rely on us to say that would be helpful for your facial rejuvenation, or that we should avoid. And so part of the chair time and the process of the consultation is to spend that time with them. And also I leverage my time through my team. So I'll have my surgical coordinator speak to them, have some girl talk or some boy talk, whatever it might be. So we all ensure with my team that we know what we're aiming for as a team for our patient. And then we can proceed forward or not.
But in your practice, you provide like a dermatologist to help you with like aftercare of the blepharoplasty, or
Me.
no? Just you.
Me. I mean, I work with all my
like
team
laser?
members. I have, resurfacing. I do a lot of chemical peel resurfacing. With thermal energies, especially in pigmented individuals, I'm more reticent. I know how my peels work better than I do the technologies, and the technologies changes. Whereas my chemicals have been there for 20, 30, 50, 100 years. And I understand pretty critically what depth I would need to go to, how many applications I can provide, and at what point the reapplication is needed. But I think addressing that resurfacing, texture, pigmentary changes, it's not just a matter of volume, it's also about the texture and all the pigmentary package to get the youthful porcelain glow that you have. To take a patient from that to this, it's an effort. It's not just surgery.
Yes.
So there's prep before and ongoing prep afterwards. It's not just surgery will fix you for the rest of your life. Again, that's part of that chair time that I use to explain to my patients, and so that we understand surgery, my laser, my scalpel blade can only do so much, and then after that there's other instruments that are required. Yes. And one other thing I tell patients is when I'm doing this, and to your point, is that, and they have to understand this before, is that after surgery they still may need filler, because we can't address all of the volume discrepancies with their own tissue. They may not have enough. So they also know that there still may be additional costs and requirements for filler augmentation at the 1 year mark. So once things have settled, we know where additional volume may or may not be needed. Yes.
If I ask you, we divide the patient to be two groups. The first group is the patient like a Caucasian patient. If you have the Caucasian patient come to you, how many percent you just to do the tan cutaneous? How many percent you just to do the tan conjunctiva? Because both technique they have the risk and benefit, right? And Asian group, how many percent you gonna go to TransCon? How many percent you go to tan cutaneous? Well, some people talk about, Cutaneous, they have bridge of the ectopian, right, and retraction, and conjunctival is have the incident of the ectopian and retraction rates, but the technically is more difficult because there's limited space.
Absolutely correct. You know, I've trained a lot of fellows, a lot of students, all of us, and we know the perils and the pitfalls when you do this kind of surgery. This is not a surgery you learn in TikTok. This is not a surgery you learn through just kind of watching one or two. It takes the sage advice of a good, experienced professor to advance that skill set, especially when you go transcutaneous. So when I have learners and I'm teaching a technique, I always start transconj. It's a safer plane, it's a more forgiving plane. The reason why people go wrong transcutaneous, can you see this diagram here? So let's just say we go transcutaneous, subciliary, and then we're trying to go along here. What ends up happening and where people get into trouble is sometimes they'll go preorbicularis, then they'll go postorbicularis. So they go in and out, in and out. So if you zigzag in and out of that plane as you get to the cheek or to the rim, that's where the problems happen. That's when we get retraction and middle lamellar issues, and that adherence is unsightly and is very difficult to fix. And we've all fixed them, especially when they come to us after surgery elsewhere. So when our surgeons that don't know their planes or get misled breach that septum, come back in front of the septum, breach the septum, come back in front, now you're in trouble. Does it work effectively? Sure. There's some people that have been doing this 20, 30 years and they only go transcutaneous. They're comfortable with it, they know their planes, and they don't have problems. You cannot argue with success. If they're successful in their approach, enjoy. Congratulations. For me, because I have so many learners and I need to get them principled, I always start transconj. And when I want to address that extra skin, Asian or Caucasian, I always do the extra pinch. So I'll go, after I've done redraped, I've done the mid-face, I've done the lower lid tightening, done the SOOF lift, SMAS, then I address the extra skin. And for me, it just means, because it's seldom that I take more than 4 millimeters vertically. That's not much. So if you look at this patient here, in terms of what that really translates to, 4 millimeters is basically the width of my arrow. It's not much. If you take more than 4 or 5 millimeters, you really need to have good reason to do that. Otherwise, you are risking complication. And the most that I take of that vertical skin actually is laterally. So from lateral, there's a triangle that goes laterally, it's more vertical, and then as I get more nasal, it's more and more medial. It's thinner. And it's like this big, long triangle. So I'm able to achieve that effectively after I've tightened everything, redraped, take a little skin, it smoothens it out, and it works very effectively in my hands. I do go transcutaneous for a couple of reasons. One, some people just need that, especially if I've got to deal with festoons. Let's talk about festoons a little bit. That hasn't come up. So many folks have got a lot of extra fluid deposition in this area. I see that more in smokers. I see that people with autoimmune conditions, thyroid patients. When I have a patient with festoons, first of all, again, the chair time, expectation management, to state festoons cannot be remedied with a blade. They cannot be remedied with that laser. I cannot stop fluid from redepositing in that area. However, if we can scar some of that down, reduce some of those glide planes there, then it will help to hopefully reduce the redeposition and the reaccumulation of that fluid. So I warn them in advance. When I go transcutaneous in those patients, I need to dissect down to where that festoon is, try and coagulate along those planes, refixate, get my SOOF and my SMAS up, and then once everything is tightened, I'll inject Kenlog at the end of the case, usually about 40 milligrams per cheek, quite deep, to try and reduce the redevelopment of that fluid. At the same time, post-operatively, I'll give them a dose of oral prednisone, usually 60 milligrams for 5 or 7 days. Also, at the time of surgery, they all get about 10 milligrams of dexamethasone or Decadron. By doing that, I can try to preemptively address the post-operative edema and mitigate the reaccumulation of that fluid. So I like the question. Transcutaneous, if it's working in your hands, excellent. Be principled, know this sagittal diagram. I always tell my fellows, I need you to draw this. You have to draw it at the beginning of the case so we can reference this diagram as we're dissecting. We know exactly where we are relative to the lid margin, relative to orbicularis, septum, SOOF, as well as our OML. Does that make sense? Does that satisfy your question, Dr. Goff?
Yeah, I very agree. Yeah, this diagram is for the beginner to remember.
And then you see the transition and attenuation. If you have that committed to memory, it's more likely you'll be a safe and effective surgeon.
Right.
Go check.
How, in your practice, how many for the fat redapping for Asian people, Asian patient, how often that you apply the fat redapping to the in front of the inferior orbital rim? Because if you try to do transconjunctival, the space is limited, and some people always do fat redapping for Asian people, but some people don't do that.
Yeah, great question. When I have patients that are 50, 60 plus, usually 60 plus, I find Asians get a very prominent double convexity and a lot of volume excess and unroofing of that fat, of the fat along the orbital rim. And so it's very noticeable, this extra, far beyond what you see here. It's bulges. Subtraction of that fat is what I've seen is necessary. The residual, then I redrape over the rim to allow a smooth transition between the cheek and the eyelid. In my hands, that can be very effective, along with tightening of that SOOF and reestablishing that orbital malar vector. What do you do? What's effective in your hands?
I love my transconjunctival lower lip blepharoplasty, and in my hand is very safe for no risk for the retraction, no risk for the ectopian, but for the part of the skin excess, we can do pinching, but pinch a little bit or pinch a lot depends. And the SOOF lift or orbitomalar suspension is the king in my it's a major part in my practice. Yeah, but I choose to do transcutaneous in some case because a lot more score for the transcutaneous, and with the pinching it can provide me the really unnoticeable scar. And how is your practice, Dr. Nu? How many percent in Asian patient that you do transcutaneous? How many percent you do transcon?
If it's in young patient, definitely I do transcon with still a good texture of the skin. But if in aging, 90% I would do transcutaneous.
Good.
I'm comfortable with that, and I never see.
And you know your planes. You know if you're going in, you know where septum is, and you know where to maintain. Do you go subdermal when you're doing your dissection, or suborbicularis when you get to the rim?
To the rim,
yes.
It's like this. It's like when you release the orbitomalar.
Yes, but when you're going transcutaneous, let's use this diagram as an example. So if you're going to go transcutaneous here, do you go suborbicularis to go down to the rim, or preorbicularis?
I try to, in some case with a very thin skin, I try to preserve the orbicularis as much as possible, but some Asian, they have thicker, so I thin a little bit to not create. Some they like the dolly eye, you know, the term. So I want them to keep a little bit, but in some they have a lot of extra when they're smiling. So I thin some of them.
Correct. It almost looks like it's hypertrophic.
Yes.
And so when I see if it's a hypertrophic orbicularis, I would subtract it when I do my pinch or in the transcutaneous approach. You can. So again, if you're dissecting, and I think the key pearl for me is when I'm dissecting along my transcutaneous approach, I have to commit to a plane if I'm going to be suborbicularis or preorbicularis, but I have to stay in that plane until I get to the rim, and then I then go past that plane and the septum to arrive at my lower lid fat pockets. So there's many different pathways or corridors we could use to get there. Just understanding that we don't go in and out of that sagittal plane, I think is
Make sure
is a
once
pearl.
you get to the septum and then
Release.
go along that and until you reach the rim and
Correct,
release
and then
everything.
I do release of the arcus marginalis.
Right.
Exactly. I think one pearl I'm trying to show here is what that's showing is that how I test whether I've got robust lift and support with my SUF lift is by pulling down on the cheek. The eyelid is not coming down, and that's an important feature to know because the eyelid is not pulling away with my fingers because it's secured with my vicral sutures. The cheek is secured with the vicral sutures right there, and then I secure the tarsus. It's that combination of securing the tarsus, supporting orbicularis, supporting orbital malar, that's going to give us durable lift and durable smoothness of that cheek eyelid junction. Great.
All right, we go ahead for the second lecture.
Thank you. Those are excellent questions. Clearly from people that know how to do this as well as have experienced all of the different versions of the challenges. So the second lecture that Dr. Goff wanted me to give was on a technique that's gaining enormous popularity, certainly in North America, and I think it's been utilized in Europe for some time. What I think prompted the resurgence of use of the frontalis muscle flap for ptosis is the fact that some of the materials have not been available. There's been variable success with the experimentation of materials, and that, I think, created a subspecialty day on this frontalis flap, or FMFA, and through that, there's been some popularity, certainly in the US, but ironically, I have no financial interest again, ironically, in Canada, it hasn't gained popularity. In fact, over the last 2 years, when I first started the technique 2 years ago, from what I could gather, I was the only surgeon within our ASOPRS group that identified as using this technique on their patients. So the rest of our Canadian oculofacial plastic surgeons were not comfortable, did not use, or did not feel that this was a required technique. In my practice in Calgary, I became the only pediatric oculofacial plastic surgeon. Over the last 2 years, maybe 3 years, I've inherited a large volume of patients, some re-ops of others, re-ops of mine, and that huge bump in about 3 million catchment area for pediatrics, and seeing patients like this where there's been 2-3 slings that were placed in these patients. And, you know, Einstein once said, insanity is doing the same thing over and over again, but expecting a different result. Why would I place yet another sling in a failed procedure on a patient? It made no sense to me. So in 2023, when we're in our Canadian meeting, this is my group of fellows, we're all having dinner together, talking about some of the challenges. A week after that meeting was the ASOPRS meeting, where I met with my preceptor, Don Kikawa, one of my cohort, Dr. Kat Burkett, and we're comparing techniques because both of these individuals, especially Don, has been using this technique for over a decade. And I really wanted to know over a beer. That's when you get the most relevant information. What works, what doesn't work. And that really is, for me, the best part of any meeting. Spending time with good colleagues, trusted colleagues and friends, and sharing ideas, sharing true outcomes. So what is the FMFA? Well, it transfers power from the frontalis muscle directly to the tarsus instead of using some material to link that, whether it's your own tissue like fascia lata or alloplastic tissue such as sling, silicone, or suture material. Indications for the FMFA are the exact same as our standard sling techniques, which is severe ptosis, poor levator function, acquired ptosis with irreversible levator damage, failed levator advancement, failed frontalis slings. Contraindications, well, if they have got severe leg ophthalmos and keratopathy, elevating that lid more is probably not a good idea for that cornea. And of course, if there is no or poor frontalis function, say from a palsy, facial nerve palsy, it's probably not a good patient. So let's look at the anatomy here. So we see the key structures. First, the orbicularis oculi, its orbital portion that interdigitates with the frontalis muscle at the brow, and this relationship is critical for dynamic force transmission. As we move superiorly, we see the supraorbital and supratrochlear nerves medially. Both must be preserved to avoid forehead sensory loss. And then laterally, we have the temporal branch of the facial nerve, which could be at risk if we dissect too far, so laterally or superiorly, resulting in paresis. Timing for surgery. Well, in children, if there's amblyopia risk, we need to certainly address that at a very young age. And my youngest patient was 7 months old. Amblyogenic, covering the pupil, and it required and compelled more urgent surgery. So it can be safely performed in babies, and I've safely performed it in patients older than 70 and 80 years of age. Psychosocial features are also important in terms of whether we intervene earlier in a child. So this was first described a very long time ago by Fergus's group in probably in about 1901. And they described this as an easy operation for congenital ptosis. However, with further development and descriptions of it, say from Song and Song in 1982, where they reintroduced a concept with an L-shaped frontalis muscle flap and other variations, it didn't gain much traction, certainly not in North America. There are differences in skin incision, extent of the dissection, flap division, but nowadays this technique is more commonly performed in its more simplistic form in Europe and in Asia. And let's analyze that. So it's our standard blepharoplasty incision. We make a skin crease mark. We excise an ellipse of extra skin. We do some inferior hydrodissection to identify the tarsus, which we can see here, highlighted in green. Next, we dissect deep. We're going superiorly towards the orbital rim, posterior to the frontalis muscle, and we can see the rim identified there. And on the diagram, we can see our plane. We're fairly deep posterior extending along to the frontal bone. That's the easy part. And this is where people, I think, found challenges. This is where my learners find challenges. So I mark where I want to start my incision, which you can see with the dotted lines. I then hydrodissect that plane between the dermis and the frontalis muscle, because it's very easy to go too thin or too deep, and then you're buttonholing your flap. Transillumination helps, using a headlight helps, traction sutures help. And as you can see, I also demarcate where the supraorbital notch is, which you can see as our safety zone. Now with my scissors, I'm dissecting along a subdermal plane, so I'm anterior to the frontalis muscle, dissecting superiorly towards the ciliary hairline. I've created this flap and it's engaged in the forceps. And one of the criticisms people thought is, well, you're sacrificing orbicularis. Other techniques that have been described do dissect and remove the orbicularis. I don't feel that's necessary. In fact, this is orbicularis sparing. All of the green area you see there is where the orbicularis is untouched. We're incising the orbicularis, but we're not excising the orbicularis. Next, we see the forceps are holding the frontalis flap, which you see right here. I use locking Moody forceps from our strabismus colleagues. That works very effectively, engaging, holding, and giving adequate traction. Once we identify the frontalis, then we secure it to the tarsus. So we're seeing, just like in a levator advancement, we do our partial thickness tarsus bites, make sure it's partial thickness, advance the frontalis flap and secure it now to the tarsus. I do temporary ties. I assess for a good lid height and contour. I use 2 sutures, not 1, sometimes even more, in order to ensure I've got robust support. And then I do lid crease reforming sutures and close. So let's look at this diagrammatically. This is the left eye, upper lid crease incision. Here's our lateral extent, about half a centimeter, just medial to the lateral canthus. And then medially, here's a supraorbital notch, and we're going about half a centimeter or 5 millimeters laterally to that. Here's my tunnel. I actually don't go that high up. I just go along maximally just above the brow hairs. I create a flap. There's no vertical incisions in that flap. I just advance it and pull with my suture and secure the flap right to the tarsus. It's not a hang, sometimes a hangback is required, but ultimately frontalis muscle is touching the tarsus. Others have described maybe just using a suture, where the hangback technique, my technique, involves securing it to the tarsus. And the results are really good. This is a patient who had surgery done as a child more than once. He has congenital ptosis. That's his pre, there's his post. This is an Asian patient, 4 years old. This is relatively soon after surgery with excellent lid height and contour. We're going to see plenty more post-ops. So let's look at this video by Kikawa and his colleagues from UCSD. This has been published already and is available online. Skin crease incision. He's advancing to identify the posterior extent of the flap. Now he's palpating the anterior extent to develop his frontalis flap. That's that same subdermal dissection plane that we saw in the diagrams. Spreading, allowing the spreading gentle blunt dissection to identify our plane, and voila, we have our flap. Of course, the video makes it look a little bit easier than it is, but with experience, it can be raised fairly quickly now. That's the pretarsal plane. Now we're passing our proline suture from the flap to the tarsus and back into the flap. Take out the corneal shields, temporary ties placed, and you can see excellent height and contour. And there's the flap. You can see a nice MRD1 on the table of about 5 millimeters. Excellent contour. That's an excellent outcome on the table. This was my index case. This was a patient that had 3 previous slings. This was in 2023 when I first started the case. This was my first case. It didn't seem right to put him through another sling, especially if he'd already failed. And like Einstein said, the definition of insanity, doing the same thing over and over again, trying to achieve a different result. That's him post-operatively with a satisfactory result. We're all satisfied. He's satisfied. He's engaging his frontalis. He gets adequate lift. So, are there complications? Sure. We can injure the supraorbital or supratrochlear nerve complex. We could possibly injure the frontalis or the temporal branch of the facial nerve. But certainly when we know our anatomy, know our dissection planes don't have to extend that far laterally or superiorly, we can avoid that. There is risk of hematoma by if you injure the sentinel vein, which I'll show you, but knowing where those structures are helps mitigate those risks. So why choose one technique over another? Again, it's hard to argue with success. If in your hands you're finding that sling works effectively, wonderful. One should keep using what works effectively, safely in your hands. However, when that sling fails and fails again, is it worthwhile to again do another sling? Or should we really always have this technique in our toolbox? And I believe, yes, we should. And that's what prompted me to consider it and then follow through on this technique. When we look at the literature, A review of over 10,000 eyes over 20 months of follow-up on average revealed that undercorrection was only seen in about 2.3% of patients, overcorrection in about 0.64%. And the three most common complications were crease abnormalities, conjunctival prolapse, and contour abnormalities, while still accounting for less than 2% of the total cases that were analyzed. So in essence, it's a safe technique, it's an effective technique by others, including myself. So in my hands, I think the clinical pros of this technique are that subdermal tumescent hydrodissection, hold the forceps flaps with the locking Moody forceps, transillumination helps me to identify my subcutaneous plane, avoid the supraorbital vein, which I'll show you, and tarsally everting sutures will help avoid an entropion. We certainly need more long-term studies, ideally doing a head-to-head comparison to see which of these techniques should be used when and to stratify that data. So this is an example of a patient, it's an adult patient that developed a floppy upper lid. So that laxity made the frontalis flap contour not favorable. So in this case, concurrently, I just did a canthal sparing canthoplasty of the upper lid, did that horizontal tightening to now I've got much better contour, I can achieve a better lift, and that allows me to get a more effective frontalis flap advancement. Here's an example of the sentinel vein shown diagrammatically here, as well as in an anatomic dissection intraoperatively. Knowing to anticipate that, avoiding it to avoid a hematoma is important. So I first started this technique when I realized nobody else was using it. There were so many failures that I saw in a practice that I inherited. It seemed the right thing to do. So with my colleagues and I assessed with my American colleagues the best techniques to utilize, and I've employed it since then in 2023. I conducted a retrospective case series over the last 2 years with myself and my fellow who's now graduated in the adjacent province, Dr. Carson Schell. We have a composition of 38 patients and 55 eyelids. 25 were children, 13 were adults. Age range was 8 months to 79 years. Gender was balanced, and we worked on a composition. I've worked on congenital ptosis, oculopharyngeal muscular dystrophy, CPEO, myogenic ptosis, as well as cranial nerve 3 palsy. The results were, for me, very impressive. I could get an average lift of about 3 millimeters. That's quite effective, and it was statistically significant. The maximum lift that I achieved was 7 millimeters. It was a patient with cranial nerve 3 palsy. The minimum lift I achieved was deliberately undercorrected for a patient with CPEO and poor Bell's phenomenon. So I was worried about corneal protection. So I deliberately didn't give him as much lift. We knew our goal was to get a conservative lift, and that's what we achieved. Complications? Well, some lag ophthalmos resolved without intervention. Last inversion or entropion occurs with this technique, just like it does with other congenital ptosis repairs. So doing the everting sutures is a real pearl. My average follow-up for the study was 16 months, but since then we've increased it to about 20 months on average with durable response. Since I've done this presentation, I've had to do one re-op. And that re-op went very effectively in a patient that had the frontalis sling was, MRD was too low. I went in about 6 months post-op, found the same flap. What had happened in that case is the proline sutures had cheese wired. So it meant just finding the proline sutures, finding the flap, re-advancing it. So in that case, I did not place 2 sutures, I placed 4, and now we'll see the durability of that case. So in conclusion, the frontalis muscle flap advancement is a powerful, dynamic, and customizable option for severe ptosis in cases with poor or absent levator function. It delivers excellent contour, natural lid motion, and avoids the limitations of sling surgery. Success depends on proper case selection and precise technique, as always. This is a collage of some of my pre and post-op cases over the past 2 years. Thank you for your time.
Oh, thank you very much, Dr. Punja. And it's very. I think I have seen for my experience. I have seen we have the cadaver dissection course in the beginning of this year in UCSD. We met together in February, right? And I think for this technique in the past 10 years, 20 years ago, it seemed to us, to me, that is no future for this technique. We heard about that. We have never seen any people do that. We have never seen the video. And this year, I went to US and joined the UCSD course. And one of my colleagues, I think Dr. Korn, right? He did the lecture and he did the cadaver dissection and show us about how to do that. And we try with the cadaver and it seemed work. So I come back after the conference and I read about 10-15 paper and it seemed that in North America for the past recent year, couple year, the popularity of this technique is go up significantly, right? Significantly. Mm-hmm. And so I come back and I have one case. I saw him, this is congenital ptosis in left eye, and I did when he was 3 years old. That may be 15 years ago, 12 years ago. And I did the fascia lata. You know what? 2 times failed for the fascia lata for revision and 3 times failed for the sling. So I decided we should do this frontalis flap. So I tried that and it worked really well. And after the surgery, no complaint, no messages, no line. The parent is 15 years old kid, and this time he can do without general next year. Previous 5 times we had to do under general, and all fail because the frontalis sling with the silicone, and the patient is a football player. He works so hard for the football. He squeezed the eye so much. Sometimes you did a silicone sling is so good for 1 year. After squeezing the eye so much for playing football, sometimes I think it may lose from the sling. So I think we tried this technique and I got a very good impression, very good result for this one. So I think it's a good start for this technique that we can try. And from your study, you have done a lot, and I think the result is very good. And I think you think this one is superior than the fascia lata, or if the one case, the new case that come, would you prefer to do this one at the first choice for severe congenital ptosis?
You've raised some excellent points. First of all, that was a great course that Dr. Korn, Dr. Kikawa, Dr. Liu hosted. It was their inaugural course, and we had the privilege and pleasure of being their faculty members. And the beautiful thing in that course was that Dr. Korn did a live surgery on that one and a cadaver lab. So on Friday, we did the live surgery, and we were moderators, and we saw him right live achieve the results that we saw in the video. It was beautiful and very effective. We've also seen their study looked over 10 years. So they had a longer follow-up than I have. And it's effective, it's durable. I think what I was surprised by is how simple it is. It's not complex. The previous papers by Song and Song, when we looked at it, the different L-shaped flaps, you're right. When we were training together, when we saw it in meetings, I thought, why would anybody ever do that technique? It seems so crazy. Like, why would we do all that? Bringing it down, this L-shaped cut. So we thought, let's just really expeditiously put in a sling, put in our suture material, and then it doesn't work, we'll just repeat it at some point. But since I've adopted this technique, and I was surprised at how effective it is, especially in re-ops, it is my primary technique. I don't ever see myself using tensor fascia lata, creating a second site for harvesting ever again. In a baby that's 7 months old, harvesting fascia lata is hard because that fascia lata is not developed. And so that forced me in that 7-month-old to do the primary frontalis muscle flap advancement. And so from there, I advanced it and through the index cases, and now clearly it is my go-to technique. Is there a place for a sling? I think so. But at this point, this technique is working so effectively in my hands. I'm enjoying it. I'm enjoying teaching it. I have surgeons from other parts of the country visiting to learn the technique because I believe all of us should know how to do it, not be afraid of it. And quite honestly, I think it's easier to do than a levator. It's easier to do, especially than a levator re-op. Levator is a far more nuanced, complex structure, intimately associated with Mueller's muscle conj and the adjacent tissues, Whitnall's. I think a levator re-op is more complicated than an FMFA, in my humble opinion. I've only done a few of these cases, but in my humble opinion, I think it's a definite must-have technique. And I'm so proud. You showed me your case, and we talked about that. I'm so proud of the results you got. It was perfect. Your skin crease formation was absolutely symmetrical. The contour was enviable. And I can't believe you did that with your first case. Imagine what you'll do when you have 50 of these. Congratulations.
So can you show us how to reach that, like in the good plane again? Can you show the video one more time?
Sure.
To like what there are some questions from the audience as well.
Sure.
How
you want to see the video or the diagram?
And tricks, where to fix to the tarsus to get a good contour.
Okay, so let's first start with, I think the most difficult thing is raising the flap. People think you've got to raise this big flap, make vertical incisions and bring it down. It's not like that. In my practice, I do a lot of internal browpexy. So coming to this plane, we do at least 12 times a week because I do so many of these for browpexy. So getting to this plane for my fellows, my learners, we do all the time. Where people run into trouble is finding the anterior plane. So let's talk about that because I think that's the challenging part. So I really firmly believe that highlighting about 1 centimeter from the skin crease incision, that's everted, but that's superior to our initial incision down here. So highlighting that is important. The other trick is you see how there's an instrument there everting. If you're not sure, I just take a needle and go from the skin to the actual start of the flap. And that tells my fellow where I want them to start cutting. So that tells us where we are on the skin side. Bring it down direct transcutaneous, emerge the needle here, and then you can identify where you start your flap. Then I hydrodissect along that plane because that creates my safety zone by separating the tissue between the muscle and the dermis. And that's where people have troubles and they're trepidatious. Where it's really hard to do is in a re-op. If they've had prior other fascia lata or a frontalis sling, that plane is difficult, or trauma. But it can be achieved. Should you do that as your first case? No. But starting on somebody that has a thicker brow, thicker skin tissue makes it easier. Starting as this is your first case on a 7-month-old baby is a little bit harder. And then let's look at the video. So this is just showing the forceps once that flap is raised. And I think this diagram shows clearly how we've preserved all that orbicularis. And here's our flap. That's just thin skin. Here's the frontalis muscle. So let's look at the video. And then we'll talk about the suture placement in a moment.
From the incision, when you cut that and then blunt dissection, it's
blunt dissection.
Blunt only, right?
Yeah. Put your scissor in there, spread. And I put the scissor in there, do a little bit of a nibble, and then I slowly spread for 10 seconds. And just doing that gentle blunt dissection works.
Do you need to cut like a... No.
Vertical cuts are unnecessary. In fact, they can create more trauma, and I don't think it adds to the effectiveness. In all of the cases I've done, I've never made vertical cuts. If it works in somebody else's hands, again, I can't argue with it. I haven't made them. I haven't needed to make the vertical cuts, so I don't. If it's effective, I'm not going to take that extra step. Let's look at the video. So here we have our skin crease incision. In here the dissection is going posteriorly along the flap to the rim. So that we all know how to do. This is the part that's hard. We're palpating along the superior rim there. Now we're holding the flap. You see how it's translating to the brow? So we know we've got frontalis muscle. And that's just a little bit of nibble and then a spread. Nibble, spread. And it's that slow spread that helps make sure you don't go too thin. Now we've got our flap raised. You can see it translating all the way up the forehead.
When you pull, the eyebrow is moving.
You can see the brow and forehead skin moving, exactly. And now we just do a pretarsal plane. Now this suture placement, how do you know where to place it? Well,
how many stitches?
I use 2. If it's a re-op, my one re-op that I've done, I used 4 because I wanted to not let it dehisce again. So now here's my tarsal dissection. Oh, pardon me. Goff, what happened? Ah, there we go. Pardon me about that.
But under local, you know right away, right?
Yes, yes.
But how
But of course,
about
with children, I do it
Yeah.
under GA.
You do exactly where you want it, or it's like a little under? Or?
It depends on how much strength they have. So usually I go for an MRD1 of 4. If it's OPMD, so it's a myogenic and I'm worried about keratopathy, I slightly undercorrect it or even more undercorrect it, especially if they don't have a Bell's phenomenon.
Right.
If no Bell's phenomenon, yeah, I have to be extra careful because I don't want to make that worse. So I'm going to stop right here. So where do I place that tarsal pass? It's the same as a levator. How do you gauge where to place your levator advancement pass? Well, they're sitting up. I see where I want the peak of the nasal peak. I'll place a little dot there so I know where my first suture has to be to establish good contour, get proper curvature. My second suture then goes to augment my first. That's my cardinal. My second one then supports the first one. So let's look at that. So that's that tarsal bite, partial thickness. And as I secure it, I get nice lift right away. Take the shield out. Look at that beautiful contour.
How about if it's over?
Ah,
Stitch
great question. Then I hang it back or I place a second suture
lower.
Just like a levator. Honestly, to me, it's the levator, but using the frontalis. It's the exact same principle. So if you're an experienced levator surgeon, that step is easy to understand. Again, the hard step is simply understanding that anterior plane of dissection between the skin and the orbicularis. That's the only challenge in this technique, is establishing this plane right there,
yes.
which diagrammatically is this plane right there. Does that make sense?
Yep. If it's still over, even you hang back already, you probably need to go and release.
Say the question again.
Even you already hang back and it's still over.
If it's still over and I've hung it back, I can take the suture out and just bring it lower. So instead of placing the suture, say up high here, I'll place the suture there.
Or does it mean that we have to release
If it's
more on the flap?
don't need to. No need to go vertical into dissection. Honestly, I know Richard Allen talks about going further superiorly. That, in my hands, has been completely unnecessary.
Okay. Okay.
There's a lot of audience ask the question. They ask about the trick to fix to get the good contour, and if they have the revision is how I think it's the same. Like there's if you have a good experience, good feeling with the levator at one end. The same.
Exactly. I was really surprised as how, so as I said, my re-op was at the 6-month mark, so there's plenty of opportunity for scar tissue. But it was exactly the same technique that I used as a levator re-op. Skin crease incision, I find my tarsus, there's no suture there. It's not there. Found my suture because the proline, you can see the blue as you're doing some gentle dissection. The suture led me to my frontalis flap, found a flap, released the sutures, just created more of a flap and brought it down again. But this time I put in more sutures and longer sutures to make sure that it secures to the tarsus.
In your practice, if you pull down the frontalis flap, and how many stitches that you fake to the tarsal plate? 1, 2, 3?
I always do 2. My first one nasal, or that first cardinal suture, and then my second one. And it's good. These are nice long tarsal passes, partial thickness. I get nice lift, nice contour, robust fixation. And as I said, I've had a 20-month follow-up. It's been very effective.
Right.
And I was surprised as to how well it works, quite honestly. I was trepidatious and reticent to take the technique because in my head I thought it was more complicated. Do you need a vertical cut? Do you make an L-shaped cut? How far superiorly do you go? Am I going to injure the facial nerve? No. Those things did not happen. I don't have any sensory changes. I don't have any numbness of the forehead. Those have not happened. Will they happen? Probably, when you operate enough, but like with any technique, but we stay principled, demarcate our danger zones, follow our technique, and we should be in a safety window in effective oculofacial surgeons. Good thoughts?
There's some questions
Yes.
from the
Please.
audience. How you fix the eyelid crease with this technique after you fix with a frontalis flap or with a tarsus to create the crease?
That's an excellent question. So it's your standard sort of entropion repair. Let me see if I have a good... so what I'm doing here, it's not showing up very well. So what I will do, first of all, is I'll show you in this diagram here. So I've trimmed some of the, so there's always a little bit of a blepharoplasty because there's redundancy. So I will subtract an ellipse of extra skin, even if it's a child. When I refixate to reduce the entropion, I'll capture the orbicularis and I'll secure it to a combination of the frontalis muscle, which is now secured to the tarsus, as well as to the levator. So it's going orbicularis, frontalis, levator, back to the orbicularis. And that effectively takes the lashes from inverting, and you see an immediate eversion. Any of us that do skin crease reforming sutures in our Asian blepharoplasty patients, any of us that do entropion repair using anterior lamellar repositioning, it's the same technique. And how many of those do I place? 3. Nasal, central, and temporal.
And the questions about how you choose about this technique compared to the sling material, which case that you will go for the sling material or you use FMFL as a first choice?
Great question. I'm struggling with that because I'm enjoying the technique so much. So I would, now that we've got restoration of some of the good slings that were not available before, I would probably use the sling more so in my CPEO patient with a poor Bell's phenomenon. That being said, one of my colleagues, one of my past fellows actually, Dr. Wendy Ming, in her practice in British Columbia, she's only been using the flap in her CPO patients. And she's had great success. So although I think that I don't want to overcorrect and maybe the sling is more forgiving because it's easier to adjust, if it's overcorrected in my people that cannot protect their cornea, so far I'm going to continue using the sling, the frontalis flap exclusively. I don't see a place for the sling right now based on the success rate and the durability of this technique.
Yeah, I do agree with you for the ptosis because when we do the ptosis, we have to take the responsibility for the rest of the patient life.
Correct.
If we do the sling, it may getting loose. We have to fix it. This one seem more permanent.
Correct.
Yeah.
Especially in my pediatric population, because this tissue will grow with the child. The sling will not, the fascia lata will not, but this will grow with the child. And I think that's critical.
Very good session, Dr. Punja. Thank you very much for provide us the very good talk and your guest experience. We have learned a lot from you, and today we have a couple colleague, Dr. Pa นะครับ from Udon Thani. She joined us also, and we got you here. Yeah, you have any comment? You have a lot of kids in Udon Thani, right?
In Udon Thani, I have a congenital ptosis, and I have a fail of ptosis of correction by sling procedure, and today I appreciate to for technique of fertility muscle fab, and I will try again in next time.
Wonderful, wonderful. I
Thank
wish you
you.
luck. I think you will be pleasantly surprised as to how easy it is and how effective it is. So I think we as surgeons have a responsibility to get stronger, better, to innovate so that we can make our patients get even better results than we had before. It's our duty. And so congratulations. I wish you well. You've got great colleagues here to work with and to learn from. And so we can all share our techniques and grow together.
Okay. Thank you.
Okay. Oh, yeah, finish. Thank you so. เดี๋ยวสิ not yet. Thank you, Dr. Karim Punja, for today's talk. So it's very nice two topics and very effective to adapt as to our practice. Okay. Very glad to have you here. Okay.
Thank you very much
Thank
for the
you.
honor of coming to your country, having the opportunity to speak. This is very much gives me enormous satisfaction
Thank you
to
very
be
much,
part of this
sir.
community. Thank you
very much.
All right.
Thank you. Thank you.
ขอบคุณคนฟังจากทางบ้านด้วยนะคะ ขอบคุณสำหรับคำถามทุกคนค่ะ
Okay. Are we
สวัสดี
offline?
นะคะ ขอปิดไลฟ์แต่เท่านี้นะคะ ขอบคุณค่ะ สวัสดีค่ะ
Good job.